بعد ما عمل تذكرة قال لي وش ابيض. لا قال لي انت you have to do an operation today. يعني انت عندك what they call the widow maker. من بس قلت له طب ترشح مين؟ لان انا عندي اصحابي كتير بس انا بس اتفرج يقدر يقول لي اللي ايده في الشغل بس رشح لي واحد شخص صغير جاي من انجلترا اسمه رفيق سليمان جاي من انجلترا عنده السي في بتاعه كويس وعنده 30 حاجه زي كده. قلت له انا ما ينفعش انا يهمني انت ترشح لي مين فروح رشحوني فعمل لي عمليه عمل لي باي باس 4 باي باس وكان عندي one of the coronaries كان داخل جوه المصل
المصل لما الكونتراكت بتقفل
اضطر يسلكه. نبتدي دلوقتي؟ هو مين اللي هيبتدي ده؟ All right, ladies and gentlemen, we're going to start this session on complicated management of combined problems. These are problems to begin with, let alone if they're combined, it becomes more problematic. And may I call upon my dear friend, Dr. Tariq Abu Nasr, to talk about neovascular glaucoma and peripheral diabetic retinopathy and cataract. Tariq Abu Nasr.
Mr. Chairman, dear colleague, my presentation today will be under the title of the neovascular glaucoma in proliferative diabetic retinopathy. Diabetic retinopathy falls in 2 main classes, non-proliferative and proliferative. The word proliferative refers to whether or not there is abnormal blood vessel growth in the retina. Diabetics can also have problems located more anterior in the eye. The angiogenic molecule that produced by the retina may float anteriorly, causing the neovascularization of the iris and causing the neovascular glaucoma. It was first documented in 1871. It has been referred as a thrombotic glaucoma, congestive glaucoma, rebiotic, and diabetic hemorrhagic glaucoma. The classification of the neovascular glaucoma can depend on the progression of the new vessels. It can cause glaucoma either through the growth of the fibrovascular membrane over the trabecular meshwork, resulting in obstruction of the meshwork, and so we call it secondary open-angle glaucoma. And formation of the peripheral anterior synechia, so we call it secondary closed-angle glaucoma. Owing to retinal ischemia and intraocular pressure damage to the optic nerve, visual prognosis in these cases is often poor. As with most of medicine, prevention is the primary goal in patients with vasculopathy. How can we manage the neovascular glaucoma? The management is approached through the following 4 stages according to the prophylactic, early, and advanced, and the end stage of neovascular glaucoma. Prevention is the single most important aspect in its management. Reducing the amount of viable retina is known to inhibit or even to reverse new vessel proliferation in the anterior segment. The mainstay of treatment is pan-retinal photocoagulation, in which most of the retina is destroyed using thousands of laser burns while sparing, of course, the macula. It is theorized that this may reduce the amount of ischemic retina, and thus will reduce the production of the angiogenic molecule causing the neovascular glaucoma. The treatment actually causes surprisingly little vision loss. It reduces the risk of severe vision loss for about 50% and resulting in regression of the new vessels in 30 to 55% of the patients. How can we manage the coexisting glaucoma and cataract? The glaucoma is our main concern. We'll start medically, and if it's failed, the surgery is the only way of treatment. Surgery in the form of Avastin injection, deep extended scleral trabeculectomy with mitomycin or Prolene or Ologen, or at the last with the Ahmed valve. Of course, we must avoid doing iridectomy, and if it's necessary, you must touch the iris with the cautery before doing iridectomy. And cataract comes later. It's not our priority to remove the cataract in this combined surgery, except if it's significant and you feel that the patient will gain a lot from removing the cataract. The medical treatment, of course, in the form of the topical atropine, topical steroids, and the topical anti-glaucoma medication, but the topical pilocarpine and prostaglandin is contraindicated because it may increase the inflammation. Avastin, bevacizumab, the intravitreal bevacizumab is the most frequent anti-VEGF treatment used for the neovascular glaucoma due to the lower cost, of course, and the systemic review of the efficacy and efficiency of the intravitreal Avastin in the treatment of the neovascular glaucoma is well established. We can use the Avastin in the form of intravitreal injection, subconjunctival, and intracameral injection. And also we can use it preoperative or postoperative or intraoperative. And here we can see the new vessels of the iris, and we are using the Avastin intracameral from 4 to 7 days before the combined surgery, thus to reduce the new vessels at the iris. Or we can use it subconjunctival 4 to 7 days before the surgery. Here is the Avastin, and we just inject it in the site of the operation. Or we can inject it at the end of operation, like this one, with the subconjunctival injection of Avastin after finishing the combined surgery. Lastly, we can use it in the three form intraoperatively, like this case. We just inject it in the anterior chamber and inject it subconjunctivally, and lastly, intravitreal. In the form of trabeculectomy, I'm using all the time now the deep extended scleral tunnel. And here we make a extended scleral tunnel till the beyond of the edge of the scleral flap here. And this scleral tunnel will ensure the free passage of the aqueous from the anterior chamber to the subconjunctival space at the end of it. Here is the tunnel. It's deep and extended beyond the scleral flap. And we can use also the subscleral Prolene suture to ensure the free passage from the subscleral space to the subconjunctival space, and we secure it with the 10-0. Also, we can use the Ologen with a slight modification in the Ologen part. Part of it will be subconjunctival, and part of it will be subscleral. And here's the tongue will be the subscleral, and the rest of the Ologen will be subconjunctival. We put it under the subconjunctiva, and then put this tongue under the subscleral space. Of course, at the end stages in the blind painful eye, the diode laser photocoagulation with medical treatment, hoping it will not end with evisceration. So the neovascular glaucoma is a potentially devastating glaucoma where delayed diagnosis or poor management can result in complete loss of the vision or even loss of the whole globe. Early diagnosis of the disease, followed by immediate and aggressive treatment, is mandatory. Thank you very much.
Thank you very much, Professor Tariq. I would like, first of all, to congratulate the organizing committee. They did what I thought would never be done, is to have cooperation between all or many of the investigative and centers for surgeries in one place, in one scientific meeting, which is very important because we have to cooperate and get multi-centered studies from all these centers that we have. And this will only happen when we cooperate together. And this is the first time I ever see this done with a combination of all the centers that are advanced for excellent services, eye service. Therefore, this is a very good step for multi-centered study. Because unfortunately, we have all been fibrillating, each of us working on their own as a muscle fiber, and at the end of the day, we are all not really producing anything. But together with the multi-centered studies, it will bring up more value to the study. And I do thank the organizing committee for this very important session.
دكتور طارق أبو النصر. I just have a few inquiries about your presentation, طارق. ممكن مايكروفون؟ ميكروفون للدكتور طارق. You showed us that you, thank you for the very nice presentation and the elegant surgical technique. You showed us that you inject Avastin using through 3 routes, intravitreal, intracameral, and subconjunctival. What do you prefer? What's your usual?
Well, in these cases, I'm using the 3 techniques because I think this is a very refractory glaucoma, and the first surgery is the most important one. So I'm taking all my tools in the first surgery.
So you
yes, I'm injecting intravitreal, subconjunctival, but the intravitreal, I'm injecting it about 3 to 4 days before the major operation. Then during the operation, I'm injecting intracameral and subconjunctival at the end of operation.
So you combine the 3 methods in one patient within a week?
1 week, yes. Okay. From 4 to 7 days, yes. Thank you.
Now we come to Sharif Gamal. He's going to present corneal opacity and cataract. He's a clever surgeon in both aspects. Dr. Sharif.
Thank you. Thank you, Dr. Mustafa. Thank you, Dr. Taha. I would like to speak about cataract surgery in the presence of corneal opacity. This is a very difficult decision because we all know that the situation in our country is not very feasible to combine cataract surgery and keratoplasty. Corneal grafts are not always available, and Dr. Sameh Al-Agha can tell us more about this issue. So sometimes we have to take difficult decisions in patients suffering from combined corneal opacities as well as cataract. In that we have to decide if this cataract alone, if we remove it, is it going to be beneficial for the patient or not? So we have to decide if the opacity, if it is not very dense to enable to hinder the vision. Also not so dense opacities in a one-eyed patient, you have to do cataract only and wait and see if this is satisfactory or not. Some people, they do not require excellent vision. They want vision enough for them to move around the house. So here again, you can take the decision of removing only cataract. Also, if patient will benefit, graft as is not available, if possible, again, you can take the decision to operate cataract only. This is a case who had corneal opacity, multiple corneal opacities due to repeated viral keratitis, and he had also cataract, and I had to take the decision to remove the cataract. There are some tips and tricks in order to perform surgery because, as we know, surgery depends on good visibility. So you have to position the eye in order to see the red reflex quite well. During the capsulorhexis, you can move the eye with the other hand so that you have the maximum visibility possible in order to perform this capsulorhexis. And the advancing edge of the capsulorhexis, you have to place it away from areas where the opacities are going to affect your vision. So it's a little difficult and tricky issue, but with a little bit of manipulations, you can easily, not easily, but you can succeed in performing this first and crucial step. The next step is removing the nucleus itself. Also, this is a very important step. And again, once you start doing your phaco, we all know that you disrupt the homogeneity of the lens fibers, and that's why you start losing more visibility, and you start again losing the red reflex that's working with you. So you might even hinder your capability of seeing well while doing the phaco. You see here, I lost my red reflex, and again I have to do my phaco inside the safe zone. I don't want to venture anywhere around or beneath the iris or near the edge of the posterior capsule. So I'm trying to bring all the lens fragments, and of course doing a quick chop is good here. We all know that, of course, any complication or any difficulty that happens in such a situation usually ends up with a nightmare. Because if you get a posterior capsular rupture or you get a dropped nucleus, then you are making things worse. Also, you are putting the posterior segment surgeon who is following you to deal with any complications that has happened to you is going to be, again, a nightmare for him. So you try to do your best in order to succeed in performing your surgery with success. We also know that irrigation aspiration is, again, where you usually tear your posterior capsule. So you have to take extra caution, in order to remove what's remaining of the cortical lens material. And you have to do this slowly. And I suggest that you increase the magnification in such a step in order to have more visibility as you are working in the plane of the cortex only. So you are allowed to increase. I'm not doing this here, but I think it's going to be a little bit of an add or a plus to do this. And finally, after you do your irrigation and take your time doing the irrigation, you can implant your intraocular lens, which usually requires no additional skill as any other cataract surgery. I'm going to show the next video of a more serious case and a more dense corneal opacity, in which I'm going to change my tactics as I realized that doing phacoemulsification is not going to be possible in such a case. والديلي ده من عندكم ولا من عندي؟ And here I'm going to implant the intraocular lens. Lots of patients الحقيقة they benefit قوي من just removing the cataract surgery and keeping the corneal opacity. واحنا كلنا عارفين ان what we see as an opacity does not have to be the same as what the patient feels when you remove the cataract and leave the opacity. He can see good in spite you deciding that this opacity is quite dense. But here we are faced with a more difficult case. This is a case which I realized from the beginning that this is not fakeable. You cannot do phacoemulsification in such a case, and a complication in such a case is a disaster. So I have to take another decision, and I have to remember my old experience of performing extracapsular cataract extraction. And but I modified my technique in nowadays with dealing with such cases. I do not do a regular extracapsular. I do a scleral tunnel cataract extraction, and this scleral tunnel extraction have improved my results dramatically. I do lots of surgeries this way now because there is no astigmatism induction, nearly no, zero astigmatism induction in such tunnel-shaped designs, and I can increase the length of my incision up to 6 millimeters and go end my surgery with a sutureless operation. This is the fashioning of the tunnel. As you can see, it's quite a wide tunnel, but also it can extend into the cornea. So 2 millimeters into the sclera, and again another 2 millimeters into the cornea will result in a 4 millimeters, and this results in a hinge that is quite sealed and requires no additional sutures when I finish my surgery. Next, you can perform the capsulotomy and not the capsulorhexis. We can see here that this is quite a dense cataract, but from a 6 millimeter opening, it can come out with the aid of a cystotome. A bent cystotome can pull out this lens from this 6 millimeter length incision. I use visco expression in order to express this nucleus out of, it's like a delivery. You have to push, okay, just like a normal labor. So you have to push in order for the nucleus to come out. And here we can see the nucleus once it popped out. Because you have done a capsulotomy, you have to be very careful with your irrigation aspiration again. And if anybody here is used to working extracapsular surgery, we know that any tag remaining from the anterior capsule can easily result in pulling out of the whole, destroying your posterior capsule. So you have to be very careful again. And lastly, you can easily implant single piece 6 millimeter intraocular lens. Be careful while you are dialing this lens again, because if you are engaging the lens, this might slip and result in injuring the posterior capsule. And again, I repeat that vision is really satisfactory in some cases, and you can also almost always have penetrating keratoplasty to perform if the required results are not enough for this patient and are not enough for you. Keratoplasty is always there for you to perform as a second procedure if this is not enough. If it is enough, احنا هنا شايفين the patient is يعني reflex is quite good. This vision had really good vision around 660, and he was satisfied with this vision. Thank you very much.
Thank you very much, Sharif. You've always been a very, very clever surgeon. The next speaker is my dear friend Sameh Al-Agha. طيب تفضل الدكتور.
انا بوافق طبعا الدكتور مصطفى نبيه ان الدكتور شريف جمال اكسبرت ان بوث كورنيال كاتراكت سيرجن. بس انا ليا ملحوظه يا دكتور شريف ان احنا عشان احسن الفيجواليزيشن اثناء العمليه في حاجتين مهمين جدا، وانت حاجه منهم ممكن انت بايونير فيها، الكابسولار ستين. الكابسولار ستين مش معموله جاست للوايت كاتراكت، ممكن استعمل الكابسولار ستين حتى لو في ريد ريفلكس مع وجود كورنيال اوباستي بتحسن جدا الفيجواليزيشن، فهي مش جاست للوايت كاتراكت، ممكن في كورنيال اوباستيز. الحاجه الثانيه برضو ممكن ان انا اثناء العمليه بفوت the lights microscope off، وممكن اعمل بالانديو illumination عند الليمبس برضه بيحسن جدا الفيو جوه الانتيريور شامبر. هي مشكله العمليات دي انت وريتها لنا مشكله فيجواليزيشن اساسا، فممكن احسن بالحاجتين دول، كابسولار ستين وبالانديو illumination.
I agree 100%.
مساء الخير جميعا. طبعا انا النهارده سعيد جدا لانه الاثنين تشير بيرسونز، الاستاذ الدكتور طه لبيب والاستاذ الدكتور مصطفى نبيه are probably the two most important influences in my career من بدايه الكارير بتاعي، فاحب اوجه لهم تحيه خاصه. My talk today is cataract extraction in the presence of diabetic retinopathy. Now, to understand the magnitude of the problem, there are 10 million diabetics in Egypt. And the general rule is that they are poorly controlled, and so a lot of them have retinopathy. And the osmotic effects of blood glucose fluctuation usually accelerate cataract. And one of the main causes of patient frustration after cataract surgery is progression of retinopathy. So this is a real problem. And the basic pathogenetic mechanism in diabetic retinopathy is retinal ischemia that leads to VEGF expression. VEGF causes macular edema, it causes neovascularization, and it leads to breakdown of all blood ocular barriers, including the blood aqueous barrier. So there are higher levels of cytokine release after cataract surgery, and clinically there is more aqueous cells and flare in these patients up to a fibrinous reaction. Now, what are the general principles of managing cataract with diabetic retinopathy? I think the main message today is do not remove the cataract unless it is visually significant or it is precluding assessment of the fundus. If cataract surgery is necessary and the fundus is visible, then macular edema has to be stabilized first with anti-VEGF injections, and proliferative diabetic retinopathy has to be treated with PRP as much as possible. If cataract is completely obscuring the fundus, then we need to consider concomitant anti-VEGF injections with the cataract surgery, and also to make a definite plan for fundus examination after the surgery. So I'm going to demonstrate these principles through a number of various clinical scenarios, and we'll start with this first scenario, cataract with a normal fundus or minimal diabetic retinopathy. الحقيقة أنا بعتبر دي برضو a combined surgery, because although these patients do not seem to have a macular problem, a lot of these patients develop Irving-Gass syndrome and they have very bad deterioration of vision after the surgery. And therefore, I will consider anti-VEGF at the time of cataract surgery in these patients, even though the fundus looks okay, especially if the hemoglobin A1C is more than 7, and if they have more advanced retinopathy in the fellow eye. لازم نبص على العين الثانية. Or a history of Irving-Gass syndrome in the fellow eye. كتير جدا بنبقى احنا عملنا عملية في العين الأولانية وحصل Irving-Gass syndrome. So this is something that will tip us towards injecting anti-VEGF at the time of surgery. Even if you decide not to use anti-VEGF, you need to use an NSAID, and probably the best one is Napafinac 3 times per day for 4 to 6 weeks. And we can even start pre-operatively. It might be a good idea to even pre-treat 3 to 5 days before the surgery. And after surgery, the most important thing is to closely follow up the vision and, if necessary, to do an OCT. The second clinical scenario is cataract with macular edema. Now, this is the first possibility, that we have very, very mild extrafoveal edema, which is the red area seen just temporal to the fovea. But we have a good central foveal thickness of about 230 microns. In this case, it is probably okay to go ahead with the cataract surgery, but we must do a concomitant anti-VEGF injection. Now, if there is edema involving the center, but the central foveal thickness is less than, say, 350 microns, it's probably still better to defer the cataract surgery. But if the patient insists, كتير جدا بنشوف عيانين بيجوا لنا من البلاد العربية وعايزين يسافروا إلى آخره, you can do the cataract surgery and you can inject anti-VEGF at the same time. And if you have a patient that looks like this, diffuse edema and significant thickening of the retina, then definitely you cannot do cataract surgery in this patient. You have to address the macular edema problem. First, make sure that it responds to anti-VEGF, and once the central foveal thickness falls below 350, you may consider cataract surgery with anti-VEGF injection, of course. So in cases of pre-existing edema in all grades, we also give topical NSAIDs, TID for 6 weeks, and also possibly pre-treat. And you must do an OCT 4 weeks after surgery. You must, it is an absolute must. and you try to avoid triamcinolone. كتير مننا في الحالات دي بيبقى عايز يحقن triamcinolone يقول لك عشان يبقى more efficacious. It might be needed in some exceptional cases, but remember that it is toxic to the retina and it can cause glaucoma. The third clinical scenario is cataract with proliferative diabetic retinopathy. طبعا لو ممكن العيان يكون عنده dense cataract ما نقدرش نعمل له fluorescein angiography. How do we know that they have diabetic retinopathy? We have to look at the fundus with indirect ophthalmoscopy, and we might see pre-retinal hemorrhages. We might see visible NVD or NVE or even fibrovascular membranes, even though the patient may not give a history of proliferative diabetic retinopathy. And our goal here is to do pan-retinal photocoagulation as much as possible prior to the cataract surgery. And if the cataract prevents adequate PRP, then we can do intraoperative anti-VEGF, and we must plan PRP or PRP completion within 4 weeks after surgery. لازم نقول للعيان قصتك مش هتنتهي بالكاتراكت اكستراكشن، لانك انت عندك مشكله كبيره في قاع العين ما تتحلش الا بالليزر. And in some cases, if available, intraoperative laser through indirect ophthalmoscopic delivery, اللي هو ال LIO, may be an option if it is available and if you are trained to do it. Now, as far as doing PRP in the presence of cataract, do not be intimidated by the density of the cataract. ساعات العين يبقى عنده very dense posterior subcapsular cataract وتتخيل إنه مش مستحيل إن أنا أعرف أعمله laser. You'll be surprised that if you dilate the patient, use a small spot size, and frequently tilt the contact lens, you can actually do laser in these cases. So don't be discouraged to do lasers. طيب قررنا ان احنا هنعمل الكاتراكت سيرجري، لكن هنعمل له PRP بعد العمليه لان احنا مش قادرين نشوف او الليزر مش بيوصل. It has to be within 3 to 4 weeks. ليه 3 to 4 weeks؟ عشان ده الويندو اللي بيديهولنا الانتي VEGF injection. طبعا عندنا two things to balance. Earlier is better to ensure coverage by anti VEGF, and while we still have a clear lens capsule. كتير من العيانين دول خصوصا العيانين السمر بالذات بيجي لهم anterior capsular phimosis وممكن very rapid posterior capsular opacification، فلو استنيت long enough ما تعرفش تعمل الليزر. And later is better to ensure clearing of corneal edema، وبرضه عشان تبقى انت متاكد انك انت لو دوست شويه على العين مش هيحصل opening للwound. طبعا you need to avoid excessive pressure with a contact lens to avoid opening the wound. نيجي بقى للسيناريو اللي بعد كده اللي هو cataract without a fundus view. يعني عيان عنده mature cataract لازم ابص على الفالو اي، لانه الفالو اي is an extremely important clue. You can ask the patient to bring old FAs and OCTs. You can do an ultrasound. In all cases, inject anti-VEGF at the end of the case. Potential benefit is greater than potential risk. احنا بنسمع كتير على حكايه ده بيعمل central retinal artery occlusion، ده بيزود التراكشن. I think these complications are overstated. It does happen in some cases, but the general rule is Avastin will be your friend rather than your enemy. And you can check the fundus with indirect ophthalmoscopy at the end of the surgery. ودايما تعمل حتى لنفسك نوت في السيرجيكال نوتس بتاعتك او في البري-operative plan. Check fundus at the end of the surgery or at least in the early post-op period. نيجي بقى للسيناريو الأخير اللي هو a patient who is scheduled to do phaco with pars plana vitrectomy. Please try to avoid phaco. يعني لو هنعمل vitrectomy we should try to avoid phaco لأنه اتفقنا الناس دول عندهم breakdown of the blood aqueous barrier. ممكن يحصل لهم pupillary block glaucoma, posterior synecdoche, pupillary membranes, IOL capture, and in extreme cases, if you're not using silicone oil, you can get tractional complications from excessive fibrin in the posterior segment, although this is quite rare. Most cataracts do not prevent an adequate view during pars plana vitrectomy. Please do not remove the cataract as a service to the retina surgeon. عشان خاطري احنا برضو هنعمل بونت جدعانه كده مع الريتنا سيرجن وهشيل له الكاتراكت استعدادا للعمليه. لو شلنا الكاتراكت ممكن يحصل بعدها فايبرنس ريسبونس فظيع جدا يخلي الفيجواليزيشن اصعب من لو كنا سيبنا العيان بالكاتراكت بتاعته. And the rule is if you can see the fundus with indirect ophthalmoscopy then pars plana vitrectomy is possible. خصوصا لأن البايوم معتمد على فكرة الانdirect ophthalmoscopy مش زي الكونتاكت lenses بتوع زمان. So if you can examine the patient with the indirect ophthalmoscope then you can do the surgery with the biome. And cataract surgery should be ideally done at the time of silicone oil removal. Type. Some of the do's and don'ts of cataract surgery in diabetic patients. Make every effort to implant in the bag. Try to avoid residual cortex لأنه ده بيزود الfibrinous response بعد العملية. And to avoid capsular phimosis, you need a relatively large rhexis of 5 to 5.5 millimeters. لو هنعمل vitrectomy in the same sitting لا مش عاوزين نكبر الكابسولار ريكسس قوي لانه ممكن اثناء العمليه الضغط في posterior segment بيعلى and this can actually push the lens out of the capsular bag. برضو anterior capsular polishing مهم to prevent capsular fibrosis. If you're going to put the lens in the sulcus, please never ever use a one-piece hydrophobic lens. اللي هم السكوير ايدج لينزز زي الاكريسوف الاس 60 وزي التكنس 1 والسنسور 1 والاكريسوف اي كيو كل دول they have a square edge. The material is hydrophobic. لما بيحصل ممكن يعملوا ايرس شيفنج. انا I lost a case مره لان انا قلت مش مشكله ده السالكس بتاعه صغير هحط الاي او ال في السالكس and it was a horrible experience. You must use a three-piece lens, and if possible, you need to try and push the optic through the rhexis to achieve an optic capture to decrease the contact between the iris and the periphery of the lens. So these are the general take-home messages. Cases with minimal or no diabetic retinopathy are very prone to post-cataract macular edema. ما تتبسطش انك انت جالك عيان دايابيتك وما عندوش ريتينوباثي يبقى انا هعمل له عمليه وما فيش مشكله. لا ممكن يحصل مشكله and this is something you need to consider. Advanced retinopathy, whether macular edema or PDR, needs to be addressed prior to cataract surgery. If cataract prevents evaluation or treatment of retinopathy, use anti-VEGF as a temporizing measure and make a clear plan for post-operative management of retinopathy. If a patient will need pars plana vitrectomy, try to defer cataract surgery, as this will make for a much smoother post-operative course after vitrectomy. Thank you very much for your attention.
Thank you very much, Dr.
Thank you very much, Dr. Sameh. I'm glad that you stressed on the deleterious effect of cataract surgery on diabetic retinopathy status. Suppose that you have both eyes with a normally appearing fundus with slight cataract. What's your plan? Or visually significant cataract dropping the vision to 6/18, for example. What's your plan? The retina looks like a normal retina or a very slight diabetic change.
I would check the hemoglobin A1C. I will always ask the patient to give me their hemoglobin A1C. Very recently, I had a patient with a hemoglobin A1C of 12. I postponed the surgery because this patient will definitely get Irving-Guest syndrome after the operation. The other thing, this is probably
hemoglobin A1C is 6.8. What would you do?
I will pre-treat with اللي هو النافيناك 3 times a day, a few days before surgery. I will use it for at least 4 to 6 weeks after the surgery, and I will tell the patient that I need to follow you up more frequently after the surgery, and if there's any slight drop in the vision, I will order an OCT.
Do you change your plans regarding the time gap between both eyes? Like he has bilateral cataract. You do one cataract today, and the patient is asking, he's very happy. Second day, he's very happy.
I think the main determinant will be the level of glucose control. If the blood pressure, if the blood glucose is controlled, I might go ahead and do the second eye.
Allow me to differ a little bit. I postpone the second eye till maybe 2 or 3 months to see the effect of cataract surgery on the condition of the retina. Because it has been repeated many times during our practice that we do a very nice cataract and the patient had a cataract of the other eye, a similar cataract of the other eye, and maybe a year or 2, the patient is much happier with the unoperated eye than the operated eye. I think we can allow some time as a test for the response of this patient to cataract surgery. Do you agree?
Absolutely أبي.
Thank you.
بنتعلم من حضرتك.
دكتور يحيى صلاح, aniridia and cataract.
مساء الخير. شكرا دكتور مصطفى، شكرا دكتور طه. This is a يعني interesting rare problem that ما بينقلش فانايريديا الديفينيشن بتاعها ال absence of iris, but actually aniridia is a misnomer. There is always a rudimentary iris at the angle. So it's a misnomer, but this is it can be congenital or acquired iatrogenic during surgery or after trauma. So congenital aniridia is rare, usually familial autosomal, can be associated with systemic problems. Most dangerously is having Wilms tumor. That's why you should screen this patient systemically. This is the only life-threatening problem with these patients. Congenital aniridia that have extreme iris hypoplasia. It's a pan-ocular disorder, which is very important to know. They are not only treating cataract if they have the cataract, but they might have macular hypoplasia, optic disc hypoplasia. They can develop cataract along the way. They have corneal, there is something called aniridic keratopathy, which is due to limbal cells, stem cell deficiency, which is really serious, and it can alter your results, and you have to follow and see these patients. Usually they have nystagmus. Glaucoma is a secondary problem. They are not born with glaucoma, but usually along the course of life in the teens, 20s, they will get glaucoma, and you should look for it and treat it. Risk of cataract increases with age. They are not all with cataract. Don't operate them unless they have really visually significant cataract, because of multitude of problems, of corneal problems. They might develop glaucoma. Many of them will develop glaucoma after surgery. So treatment. Try and treat glaucoma medically or mainly surgically. They need this surgically. Treat the limbal cells, stem cells according to الديجري بتاعتهم. ممكن من lubricants لغاية لما نعمل limbal stem cell transplantation, and then start treating the cataract if significant. You have two problems in these patients. You have the cataract, which is causing the additional deficiency in vision, but also they have the photophobia and the glare due to absence of an iris. So many procedures can be done to replace or to add a shield to avoid this glare. One of them is in the glasses, spectacles, tinted contact lenses. And then there was intraocular lenses like these ones, and they are nice, but they're huge. They have to be fixed in the sulcus. And there has been the segments, iris segments. And nowadays we have the iris prosthesis. There are different kinds. One is exceptionally good, which is the human optics, but it's very expensive. So follow-up of this patient are lifelong because of many disorders they can develop after the surgery. It's not cataract surgery, you forget the patient. This is a case of bilateral congenital aniridia with congenital bilateral cataract and subluxated lenses or small lenses. So she was operated in one eye first. And then, as we deal with any subluxated cataract, mainly irrigation aspiration, you evaluate if you need to put a capsule tension ring or not. Here was not. And then we implanted the lens inside the capsular bag. And then we thought of treating this aniridia by injecting an iris prosthesis in the sulcus in front of the lens. You can implant it in the bag. You can trim it and implant it in the bag. This is the post-operative course of the patient. She had later on been operated for squint, but she was dramatically improved, very beautiful. She was very happy, but she developed later on, after 1 year, started to have glaucoma, and then she had developed keratopathy. Acquired aniridia can be partial, extensive, heterogenic, or traumatic. They have better long-term prognosis. This is a child that we had a ruptured globe. Iris was excised, so he has a acquired aniridia. Aphakia, the cataract was removed at that time at the primary repair, and he was referred. So you have here to correct the aphakia and the aniridia for the cosmetic and photophobic or glare effects. So there is no capsule remnants by any means. So here the plan was to implant with a scleral fixation lens. This is the 10O Prolene. Making a small incision using a 3-piece foldable lens. Was fixed in the sulcus. Here the anterior chamber maintainer was used because this patient had done in the primary surgery anterior vitrectomy and the tension was soft. And then after fixing the lens in the sulcus, this iris prosthesis was folded. You can use it with a folder or by hand. Here I prefer to fold it manually like this, not with an introducer, so as I can control the unfolding and the positioning of the iris prosthesis. Because it's big, it's not easy to unfold. Now you can, if you use it, we do a tri-fold. This is the third example. باقي وقت قد ايه؟
هو الحقيقه لا
3 دقايق؟ طب كويس. This is the third example. She have done. She had ciliary body melanoma that was removed perfectly by Dr. Hani Hamza, and then she came to me with this subluxation and defective iris, and then cataract. So I did her cataract with all the rules of how to deal with subluxation to avoid any vitreous prolapse through the areas of defective zonulisis, making a smaller rexes, extensive hydration of the content because this is a soft cataract in a way, and at all times making sure there is no vitreous prolapsing through the deficient area of the zonules. Here I'm using the iris repositor to fix the capsule in place and to stretch it while I'm using the phacoemulsification. Here is used as an excellent, efficient irrigation aspiration machine. So it decreases the time of manipulation. This is inflating with viscoelastic, and here viscoelastic tamponading the area of zonular deficiency. Sweeping movement to check if there is any vitreous. You have all during the surgery to check there is no vitreous. Here I'm stretching the bag. And then loosening of the cortex because I intend to implant a capsule tension ring. This is an injectable, the one put with an injector, which is really nice and handy. You're injecting, making sure that you enter into the capsular bag and making sure your plane of rotation is within the iris plane so as not to have the other end of the ring outside of the bag. You can help it to center the lens and to stabilize it. Then I continued irrigation aspiration for the loosened cortex I have hydrated before, which makes it easy because usually if you do irrigation aspiration after implanting of the capsule tension ring, it is difficult to do proper irrigation aspiration. then implanting the lens in the capsular bag. This is a three-piece lens that will help the capsule tension ring to be centered, to center the capsular bag. You can do a capsular capture if you feel that centration will not be perfect, where you capture the optic and leave the haptics in the sulcus. Actually, this is what was done here. And then I put the iris prosthesis in the sulcus in front of the lens. So aniridia is a complex problem. The congenital aniridia type is much rarer than the acquired type. You have to deal with each with a different strategy, understanding of the disease that is affecting, in congenital cases, the whole eye from the cornea till the optic nerve. And there is systemic association like Wilms tumor to the acquired aniridia that we can all see and face in our daily practice, and to know the prognosis is better, but we have a lot of tools to solve the problem. Thank you for your attention.
Thank you very much, Dr. Yahya. Maybe a question. Do you have any question? طب دكتور يحيى ممكن أنا أسألك? Which type of OVG you use to prevent escape of vitreous in cases of subluxation?
This is a interesting question. I usually use viscodispersive.
Viscocohesive remains there, and if you suck part of it, it all comes immediately. Then you have a bare anterior hyaloid. Dr. Rania Al-Isawi is going to talk about the combination of ptosis and strabismus.
Good afternoon, everyone. Thank you very much, my dear Professor Dr. Taha Labib and my dear Professor Dr. Mustafa Nabih for inviting me to talk in this session. اللي أنا الحقيقة بعتبرها session العظماء. كل اللي كلموا قبلي كانوا عظماء، والحقيقة this will make my mission very difficult to gain your attention. However, maybe the complexity of the subject will gain a little bit attention. I'm going to cover in this presentation a number of conditions that the surgeon is encountered in it with the presence of both strabismus and ptosis. في other conditions iatrogenic زي following horizontal muscle surgery or vertical muscle surgery or Botox. However, this will not be covered here. In each condition, we shall know was the ptosis that caused the strabismus or the reverse, or is it just an association? And shall we proceed with the ptosis surgery first or the strabismus, or better make a simultaneous approach, or better conserve? The first disorder is the simple congenital ptosis, and as we all know, it's a congenital dystrophic muscle. Usually there is no problem, it's a straightforward case. However, in a recent population-based cohort study conducted by Moni and his colleagues at the Mayo Clinic, Minnesota, using the registry of Minnesota, they found that in every 10 patients presenting with simple congenital ptosis, one of them is also affected by strabismus. Not only that, but it is not attributed only to the occlusion by the closed eyelid, but it is present even without occlusion of the visual axis. Strabismus was found to be predominantly horizontal, equally divided between esodiviation and exodeviation, and if there is a vertical deviation, it is usually associated with horizontal deviation. Such a patient presents with left congenital ptosis, but as we can see, there is a minimal esotropia of about 15 prism diopter. The lid is closed, it might be covering the pupil or visual axis, but it actually does not preclude vision. And in this case, we should tackle the patient according to the situation. If the ptosis is severe, then of course we have to uncover the visual axis. But if we have strabismus, then we first do refraction, cycloplegic refraction. We might do occlusion, and then in severe cases, we might need surgery if it doesn't improve. And so we should do a staged procedure. In oculomotor nerve palsy, the patient presents with a total ptosis, and there is exohypotropia, as we can see. Therefore, we also have to tackle both of them, both the ptosis and the strabismus. If there is a good motility past or near the midline, we can do a simple recess resect, but sometimes we need to do a transposition operation, and therefore we usually do the strabismus first, and then we do a brow suspension for the ptosis. This is another condition also, but it is a little bit complicated because the patient has a recovered third nerve with a disinnervation. So whenever he tries to elevate the eye by the inferior oblique, there is also elevation of the lid. So this is a misinnervation. This would make the operation a little bit more complicated. However, still we have to do something for this strabismus dendritosis. Staged or simultaneous surgery in both of the previous conditions. This has been the subject of interest for many investigators recently, and many papers have been published regarding whether to do the strabismus dendritosis or do both of them together. And the result was that they concluded that the combined eyelid malposition and strabismus surgery can be successfully performed in selected cases, particularly when the strabismus involves the horizontal rectus muscles. However, it is not recommended in cases involving the vertical muscles. Another condition is the Duane retraction syndrome. The patient may have a subtle or moderate ptosis, and of course there is the co-contraction with the narrowing of the palpebral aperture. Another case also showing a left moderate ptosis, more apparent on adduction. In such cases, if we treat the strabismus by recession, of course, which is recommended in these cases, sometimes we have an acceptable cosmetic appearance, and therefore we don't need to do anything about the ptosis itself. Other cases of monocular elevation deficit, however, the patient has a considerable amount of ptosis together with the hypotropia and with the limitation of elevation. If we look at this complex picture, we will find out that the patient cannot elevate the eye either up and in or up and out to be differentiated from a Brown syndrome. And the recommended surgery here for the strabismus is usually a nap or an augmented nap where both the medial and lateral recti are put adjacent to the superior rectus and an augmentation suture is taken, or a modified nap where the half of the tendons of the muscles are put aside of the superior rectus like the spiral of Thilot. So in this case, if we manage to find the treatment for the strabismus and the patient becomes now more or less in the hypotropic eye becomes in the horizontal level, we are left with the ptosis. Sometimes we need to do an operation for the ptosis, sometimes not. We can have a clue preoperative. When we examine the patient preoperative, as in this condition, if we cover the right eye, the left eye will regain fixation, and we will find that the ptosis improved dramatically. These cases usually do not need later ptosis surgery. But in such a patient, when we covered the right eye, the left eye elevated, but not much. Still, there is a considerable amount of ptosis. So the ptosis may be true or false, and we have to tackle it after doing the strabismus surgery. Patients with congenital myasthenic syndromes or myasthenia gravis present with a variable amount of ptosis that is characteristically different according to the fatigue and the level of attention and during the time of the day. Like this patient, when we examine these patients, we will find that the lid level is not constant. It is, there is a little bit of elevation for 1 millimeter up and down, what is known as the Coggin twitch sign. And also, if we let this patient look down and then up for many times, the ptosis increases. If we tell the patient to look up and stay looking upwards for some time, also the level decreases. So these patients are easily diagnosed if we do meticulous assessment of the lid level. These patients are diagnosed by Tensilin test. However, we do not recommend this test much because it is really hazardous. If the patient has a heart block, you should give atropine with the test. So better than that, if possible, we can do an electromyography where we will find more than 20% decremental response. However, this is not usually feasible. Acetylcholine receptor antibodies in serum is also a good test. However, it is only positive in 50% of cases. So we are left with the best one up to now, which is the IcePack test. If you put an ice pack on the closed lid and keep it for 2 minutes, and then remove the ice pack, you will find that the ptosis improved by at least 2 millimeters. And this is sensitive in about 95% of cases, but the best test is the therapeutic test, where you give the patient actually the treatment as if he's already myasthenic, which is mestinone, for about 2 to 3 weeks, and you will find there is improvement of the myasthenia. And the level of the lid improves much. Sometimes it is 100% normal, and sometimes there is a residual ptosis that still will need some intervention. Another condition is the chronic progressive external ophthalmoplegia, which is a mitochondrial DNA mutation disorder characterized by histologically the finding of the ragged fiber on muscle biopsy. There is also a chronic progressive external ophthalmoplegia plus with ocular involvement, cardiac, endocrinal, CNS, and there is the syndromes. The most famous is the Kern-Sayre syndrome with pigmentary retinopathy in children. Characteristically, these patients have absent bells. They have poor orbicularis function. They have a progressive disease. So doing a brow suspension will not actually be helpful because it will probably recur, and it will probably lead to corneal complications because of what we're saying about absent bells and poor orbicularis. And if you're going to do a brow suspension, it is better to use something like the silicone rods and don't use something like the fascia lata or the Gore-Tex so as to be reversible if needed. And actually, the crutch glasses may be the best choice in these patients in old age. The congenital fibrosis of the extraocular muscle, what is now called congenital cranial disinnervation disorder, is also a condition that will need surgery for both strabismus and ptosis. It's better to be staged. However, they are very difficult cases. I'm about to stop doing any cases like that anymore because, for example, this case, which has an enophthalmia and a toast lid, and the eye is rotated upwards. This is a very rare case, but it's actually very difficult to get the eye downwards by all means. And if you can't get the eye downwards or get it upwards, if it is hypotropic, then probably you don't have to do anything about the lids as well. Webino syndrome, of course, bilateral internal nuclear ophthalmoplegia, and craniofacial anomalies, such in this case, we find both ptosis and strabismus. Also, they can be tackled at the same. ممكن أخد دقيقة زيادة؟ Thyroid eye disease are usually presented by lid retraction, but sometimes we can find ptosis with the thyroid patient or when they are in a hypothyroid status. And there is also strabismus. We can find strabismus with these cases. This is a mild ptosis in this patient. Also, we have to exclude thymoma because sometimes this is myasthenia associated with thymoma associated with the thyroid patient. Neurofibromatosis or plexiform neuroma are very difficult to treat because it is not just strabismus, but the whole globe is displaced, what we call a dystopia. And whatever treatment you do is a debulking surgery and just repeated surgeries in order to reach a satisfactory level. Sometimes you cannot reach that level. But what is nice about these things is that recently there is a talk about what is called the MEC trial, where they found out that the cause of this situation is a somatic inactivation of F1 gene, which causes elevated level of activated RAS, activation of RAS mitogen activated protein signaling, and therefore cellular proliferation in neurofibromatosis patient. So if we use MEC inhibitors, such as the new serometinib, we can find improvement in these conditions. And in the first data of phase 1 trial of selumetinib for inoperable plexiform neuromas in 24 children, there was a reduction of more than 20% of the tumor using this new treatment, and it was administered orally, and there were no recurrence after or disease progression in preliminary data. And these are the survivors of this MEC trial, which is going to be the hope to make this treatment the first line of treatment in neurofibromatosis, allowing for easier debulking surgical operation. Thank you very much.
Thank you. Our next speaker is Professor Mustafa Nabih, who will talk about iris repair in the course of vitrectomy.
Frequently, we have iris problems in cases for vitrectomy, especially those as a result of trauma. This is a subluxated lens with mid-dilated pupil. Here we are performing the capsulorhexis in this subluxated lens. It's somewhat difficult, but it's almost always doable. The lens is not hard. So the removal of this lens, especially after thorough hydrodissection with expulsion of the lens content in the anterior chamber, was not a problem. But now at the end of irrigation aspiration, vitreous started to come out using by manual vitrectomy. Actually, this was not a great problem because I know the patient has a detachment. I have to go ahead with vitrectomy anyhow. Sweeping the vitreous from the pupillary border allows finding of last strands of vitreous to be removed. Then I'm inserting a capsule tension ring in order to guide this ring manually without an injector through the capsular bag. I am using a bimanual technique, the spatula elevating the capsular bag, allowing the capsule tension ring to be swept inside the capsular bag behind the spatula. Then a single piece foldable lens is inserted. Now the vitrectomy is completed, peeling the internal limiting membrane to get rid of this traumatic macular hole. Now we have reached time when both anterior segment and posterior segment are fixed. The pupil is adequately dilated to allow for fundus examination. This is enough for this case. This is another case with traumatic giant tear with the traumatic mydriasis. Actually, the surgery for the giant tear was not difficult at all. Using the perfluorocarbon, attaching the retina, performing the usual vitreous work. Then it comes now to repair of iris. I'm using the vitreous forceps to hold the pupillary border, then thrusting the needle through one end of the nimbus across the dilated pupil to engage the other side of the pupil, then come out within the hollow of a cannula. Now I am using the end gripping forceps actually as a ring, just to pull a loop of the thread, partially keeping the remaining part of the thread to the other side. Then using one limb of this loop to perform a triple throw knot, holding the other end attached to the needle with the forceps, then cutting the needle. Then I have a knot outside the eye. If I pull the two ends of the suture, I am guiding the knot inside the eye through a very small incision. This is actually the well-known Sipser's technique. One knot is not enough. You have to add another knot with the same way, externalizing a loop. Then one limb of the loop is used around the forceps, preparing the knot outside the eye, then pulling the knot inside. Now we have a reasonable size of the pupil, nicely dilated, nicely rounded and central. This is a case of traumatic posterior dislocation where I expect not to have any capsular support, of course. I am preparing the flaps for a scleral tunnel fixation, frequently called erroneously glued lens. You don't need a glue actually. My shape of the flap is L-shaped. Then through the bed of this flap, I am performing my vitrectomy. You can see that the pupil is moving with the moving vitreous. Here I have a medium hardness lens dropped in the vitreous cavity. Using the vitreous cutter, I am debulking this, removing whatever I can remove of the cortex with the cutter, performing the vitreous base removal. Then to deal with the hard nucleus, I am going through a 20 gauge scleral incision using the bare phaco tip inside the vitreous cavity. Actually, it is very effective and very rapid too. Of course, you have to hold the lens and take it away in the middle of the vitreous cavity, away from the retina, then emulsify it. It ends the lens in a minute. Then I'm going to the pupil now, testing how much of the pupil tissue I have. Moreover, removing any membrane on the pupil surface. Now I feed the iris of the fibrous tissue, then preparing the tunnels with the 25 gauge needle underneath the L shape. So I'm sure that all my haptic is going to be covered. Then using the shaking hand technique, delivering the leading haptic of the intraocular lens outside the eye underneath the scleral flap, then going to the other flap through this, the sclera. I am getting the other haptic and inserting it underneath the L-shape scleral flap, then going to the iris, performing now a suture. Actually, Sipser's technique is very good, actually, but if you have already small incisions in the cornea, you don't need it. You can externalize the Prolene sutures and tie them outside and let them inside the eye. Now I have a nicely centered lens, sclerally fixated without sutures and a sutured pupil. This is a case of landmine injury in a police officer in Sinai. The cornea is dusted with this gravel from explosion of the mine. You see the defect of the iris. I went with the 23 gauge vitrectomy, starting to remove this soft cataract. The small white thing that you see at the vitrectomy cutter is actually a piece of the foreign body, another piece of sand or stone inside the lens. For a better visualization through this already damaged cornea, I'm using endolight to allow for better visualization of the anterior capsule and the cortex. Now the capsular bag is completely cleaned. Then I go clean the vitreous of the vitreous hemorrhage. These are pieces of sand on the retina. I go to them one by one to suck them, of course, very cautiously so as not to engage any adjacent retina. So far, I don't have any breaks. I don't want to end by having a break. Then we come to the anterior segment once more, creating or restoring the sulcus. I'm using sharp dissection between the anterior capsule and the thickened adherent iris. It is adherent on the temporal part, but in the nasal part, it is free. So I went to the initially dissected area, injected a bolus of cohesive viscoelastic, tried once more to extend my dissection. I failed, so I went to the other side of this very dense synechiae, created a plane, then went through this plane with the viscoelastic, ballooning the iris, then cutting the iris on both sides of this synechiae. The small scissors failed. I had to use large scissors. The iris was thickened by the trauma and inflammation. Now I have the iris separate from the cornea, but there is an island of iris tissue on the anterior lens capsule. I could go through the periphery of this and peel this iris of the anterior lens capsule. It is attached to one part. Now I'm using the cutter to remove the remnants of the iris. Then the sulcus is open, the vitreous body is clear, and I have two pillars of coloboma of iris. I could insert my lens within the capsular sulcus, then going back to the pillars of the coloboma, suturing the iris, passing the needle through the cornea, then engaging both pillars of the coloboma, allowing the needle outside the eye, then tightening the suture. And this is the end appearance of this case, where I have the intraocular lens nicely centered, the pupil reconstructed, and the vitreous body clear of any hemorrhage or foreign body. This is another technique. This is another technique of dealing with the iris. It's a recurrent case of retina. The retinal work was a little bit complicated, but what I'm showing in this case is how to deal with this permanently dilated iris. Another way is to perform a purse string suture around the pupil, through a corneal incision or just even a puncture by the needle. You go engage the iris 2 or 3 times. Then now you have to retrieve the lens through an incision, making sure that the lens tip should not engage any iris, any corneal stroma. Now you see the lens passing through the iris, pulling this, then redirecting the needle and reintroducing the needle through the same incision, engaging the iris 2 or 3 times, exactly like I did in the first step, then withdrawing the needle. Repeating this, redirecting the needle, withdraw the needle through an incision, not engaging iris stroma, then redirecting the needle, engaging the iris 2 or 3 times once more. I have now a Prurine suture surrounding the iris. Just by pulling the thread, I have a central rounded pupil. Thank you very much.
Thank you, Dr. Mustafa. It's been a very interesting presentation. Thank you very much.
Okay. Shall we end this session now? Do you have any questions or comments? You cannot believe 612. 612. Yes. Yeah. Of course, this is much better than doing PKP with the possibility of rejection. I hope it remains the same. Thank you very much for your attention. We are concluding this session. Thank you very much.
من عندي ولا من عندكم؟ انا ممكن نديك الفلاشه وخلاص. ممكن عندي، ممكن عندكم. هاي هاي.
ده فيجا.
فيجا معاك؟
ثانية
فيجا هنا؟
ثانية أجيب.
فيجا صغيرة كده بره. خلاص ما نشتغل بقى، مش ابل هنا. لو ابل هنا نشتغل ابل هنا، مش هنخلص يعني. مش عندكم ابل برضه؟ مش ده ابل؟ مش ابل؟ ابل. طب ما انت هيشتغل؟ حط الفلاش. مش عندك باوربوينت؟ تفاحة اسكت، حاجة غلت قوي. رحت اشتريت واحد السنة دي اتبهدلت يعني. الوصلة بتاعتها السي دي سي الصغير دي عورتني. وصلة ب $71. واحدة ب $70 يخربني. مش ممكن. عارف السي دي اللي USB C الجديدة دي؟ زبالة، كل حاجة عايزة كونكشن. شبل يعني. شايف؟ هنشتغل من عندك بقى. خلاص. فين الفلاش؟ اجيب السيشن كام؟ لازم اتفضل. يا عم اديله رقم السيشن، حد يسعى. 17. طلعنا على الهواء. طلعنا على الهواء. السلام عليكم. طبعا بشكر تاني المنظمين وعلى راسهم اخويا وحبيبي الدكتور هاني حمزه اللي مش معبرني بيكلم اللي جنبه الدكتور محمود سليمان، وبشكر شركه باير على دعوتي ان انا ادي المحاضره النهارده. النهارده هنتكلم على الايليا ان ريل لايف براكتس. انا عارف ان احنا بقالنا يومين بنسمع علم وستاديز وساينس. I will not touch this except in 2 slides, but I will start in my clinical experience, and I always talk to my colleagues about what they use and how effective it is. We all know that ILEA is or aflibercept is a fusion protein for intravitreal injection that traps VEGF-A and placental growth factor molecule, so it has a double action. And this is the binding. It's a very strong binding, preventing the VEGF and the placental growth factor from its sites. So it is a very effective and has a dual action. We have many studies. We are not going to speak about this, but we all know that we care about diabetic macular edema, age-related macular degeneration, and recently myopic CNV, which is the most common vascular and retinal disorders we use the anti-VEGF in. So the VIVID and VISTA, they used the aflibercept versus laser and aflibercept 4 weeks versus 8 weeks, and they kept the vision after the end of the study with improvement of 10 to 15 lines. Then came the view 1 and view 2 for the age-related macular degeneration, which was a wide world study, including the Americans and Middle East and the Asian area, and they were comparing aflibercept also 4 weeks, 8 weeks, and to ranibizumab, and again, they all were comparable. And the last study is the MIRROR, which used aflibercept in myopic CNV and also was effective. Let's speak about the real-life practice. I know, and I am still one of the people who used, starting with the cheap type of anti-VEGF, and up till now, we start with a cheap type because we know that we cannot afford long-term sometimes, except if the patient is insured or he had support. So we used to switch from Avastin to Lucentis to steroids when we didn't have the Eylea. And when the aflibercept came in, we started to switch again to the aflibercept. We didn't start as a naive patient, but we used to switch from one drug to another. And most of the recent study, they switched directly to aflibercept when they have resistance to anti-VEGF. In the next few slides, I will show you my clinical experience in this. Let's go to cases, like a case of diabetic macular edema. This patient was injected for 3-4 times, and you can see the extensive laser marks. And he came to me after 3 injections of Avastin, and there was no improvement after that. And in these cases, the shift, sometimes some people use steroids, but I shifted to another anti-VEGF, and I was astonished that the Eylea worked in the first injection. We all know that there is nothing called one injection, but at least the response was marvelous, and the patient improved rapidly. Again, I started to use this in the resistant cases. Here is a persistent diabetic macular edema with a very poor response. First injection, second injection, and third injection, the patient did not improve even 10 microns. Then I shifted to Eylea, and I found a very good response, but this is not the first injection. This is after 3 consecutive injections. So sometimes when you shift from one anti-VEGF to another, because of the mechanism is different, sometimes you get a very good response. Then I started to think, why don't I start if the patient can afford this with a naive patient? So I have this female patient, and I will tell you her story. She's 55 years old. She had diabetic edema for 15 years, and she has bilateral diabetic macular edema. And I always, as I said, start by Avastin. And I gave her Avastin, and I always take the patient after 3 weeks. I don't wait for the 4 weeks to see the response. And I know from the first injection how the patient behavior will be. So I looked at her, and I looked at the numbers, and I looked at the macula, and I said, this patient is not going to respond to Avastin because there is almost nothing happened after the first injection, though I will continue the injection. But in the next week, I had injection of Eylea, and I have a spare part. So I injected her left eye with the Eylea, and I was astonished because of the first injection had a very good response. So sometimes the patient does not respond to one type of anti-VEGF, they respond to the other type rapidly. So I continued for her the Eylea, and as long as she could afford that, and it was a marvelous response in both eyes. Then I started to see cases of CNV, and I always say that CNV, sometimes with the fibrovascular retinal pigment epithelium detachment, you have to attack rapidly and quickly. And I had a very good experience with all of the anti-VEGFs, but this is a patient who had 636 in the left eye. He is hypertensive, uncontrolled, with left diminution of vision. And look at the OCT. The right eye only drusen, and the left eye fibrovascular RP detachment with a cystoid macular edema, diffuse thickening of the macula. And I told him that we will start by the strongest one, and I gave him the Eylea. And again, I was astonished because the first injection gave 6-12 vision. I was astonished because only one injection did this, but we all know this is a lifelong disease. We cannot tell the patient that this is the only treatment for one injection, go away and don't come back. I continued the injection until the patient was completely dry, and I gave him consecutive injections, second and third, and then I looked at him, he reached up to 6-9, completely dried macula, and I told him I always use PRN, I don't like the treat and extend much, because sometimes you force the patient to take something he doesn't need it, but I looked at him and I said, let's follow up PRN every 1 month, and he was quite stable, but 2 months later, he came with recurrence activity, 6-18 vision, and I started to give him PRN one by one, and I looked at the macula, it's getting much better, but when I looked at it, and yesterday I presented this in a course, look at this, don't consider this a cystoid macular edema. This is not a kind of cystoid edema. This is like outer retinal tubulation. It's a huge part. And we always need to confirm that the CNV is active or not by OCTA, and look at the OCTA. And after the injection, with second injection, I looked at the vessels, very long, filamentous, dry. I don't have to inject anymore, though this is still there, but this is not a sign of activity. So again, it can work rapidly, but nothing works forever, and we have to keep monitoring the patients. Follow up 3 months, still stable, 6-12 vision, and I don't have to inject anymore, and I follow him up every 3 months. So I got this patient, she's a relative to mine, she's almost 78 years old, and she had a wet AMD, and she has extensive exudation. The exudative detachment, we can see the exudation, we can see the RP detachment. Most probably this is a fibrovascular retinal pigment epithelium detachment. And again, from the first injection, she had completely dry macula, but I kept injecting her until I was sure that she dry after 3 injections, and I'm following her up. Then I met this case. This is a very peculiar case, very irritating patient. She's a female patient, age 51 years, and she had left sudden diminution of vision, and she presented with this OCT, fluorescein, and I had to scan the OCT, look at the picture. It's a bad quality, but you cannot see anything under this hemorrhage. And most of the time when we see a young patient like this without any history, we think of polypoidal because this is the cause of massive hemorrhage. But I couldn't get any polyp, and this is the right and left eye. The right is completely free. It's not an age-related macular degeneration, but I looked at her, probably she's a polypoidal, and this is the OCT she had. She had something elevating here, so probably multiple polyps, and caused rupture and caused this massive hemorrhage. And the patient, she was going from one doctor to another. She went all over the country, Cairo, Alexandria, and she came back to me, can I inject in this eye? And she presented like this. 2 months later, with the hemorrhage still in the macula, still dehemoglobinized blood, and it is resolving, but she does not see. She's still counting fingers. And she said, can I inject? Would you promise me if I inject, I will be better? I said, you might be better, but your fovea is jeopardized and you have to inject quickly, otherwise you will lose your vision. And this is the OCT I repeated. Still, we have exudation, and I looked at her. Still, we have elevations here, probably 2 small polyps. And I went with the OCTA, and I found, yes, 2 small polyps under this elevation, so it's a polypoidal. And we all know that polypoidal only responds to PDT, and it's a very poor response to anti-VEGF, but in the literature, Eylea can do that, so I started to injected her, and she's getting dry, she's getting much better, and the polyp is getting much better, and I always look at the polyp because I know where it is, and I always concentrate on this, seeing the overlying fluid, seeing what's underlying. And this is 1 month after the second Eylea, she's getting better. And 1 month after the third Eylea, she's getting much better. And you can see the flow is getting much, much less in the OCTA, though she didn't improve much because of the affection of the photoreceptor, but at least from counting finger to 636, it's a very good achievement, and we could get rid of all the hemorrhage, we could get rid of the elevation, and the polyp is completely quiet, and I have to stop injection with a stable vision for 636, and this is her last OCTA with a very quiet eye. Lastly, myopic CNV. We all know that myopic CNV is the best in treatment with anti-VEGF. So I tried with this patient. I gave her only 1 injection. We all know that they respond very rapidly, not like the AMD, and complete regression after 1 injection. And in this patient, we don't have to repeat the injection. We can follow them up PRN, and sometimes they don't need except 1 or 2 injections per year. So my take-home message is aflibercept is a safe and effective intravitreal anti-VEGF. It is a drug of choice in resistant cases for my clinical practice. I switched directly to Eylea. It's equally effective as a first line of treatment when it's affordable. We all know that sometimes the patient cannot afford, but when it's affordable, I use it as a first line of treatment, and it's effective in PCV when PDT is not available, and also in myopic CNV. Thank you so much for your listening. I'm not expecting any questions. Thank you.
طيب احنا عندنا اجهزه الفوتنج موجوده في الديسك اللي ورا عند الباب، فمحتاجين ناخدها بسرعه لو تكرمت. لازم كده. طبعا جلسه الديبيت من افضل الجلسات دايما في الميتينجز. انا اتشرف ان معايا الكو تشيرمان صديقي دكتور سامح الاغا. عارفين ان احنا بنبدا عندنا ديبيت بكويستشن and then you will vote for the question and then we will listen to the talk and then we will re-vote again نشوف هل السبيكرز قدروا يقنعوكم بافكارهم ولا لا. عندنا سلايد تشينج ان ذا بروجرام. احنا هنبدا ان شاء الله بالتوك اوف فيمتو فيرسس مانوال كيراتوبلاستي، دكتور رياض شلش فيرسس دكتور محمود اسماعيل. هنبدا بالسؤال في الاول قبل ما نبدا البرزنتيشن. first question and then اذا احنا بادئين من ان احنا we prefer the femto keratoplasty. اوكي. دكتور محمود اتفضل.
بسم الله الرحمن الرحيم. نحاول نقنعكم بالعكس. انا شايف ان الفيمتو كيراتوبلاستي يعني تيكينج اوفر، بس انا هحاول اكون
محتاجين نعمل. طب دكتور محمود معلش نستأذن حضرتك في حاجه بسيطه. السيستم بتاع الفوتنج كالتالي، انتوا ماسكين الجهاز في ايدينا، عندنا A B C وبعدين عندنا في الاكستريم رايت فوق اوكي اللي ان جرين، فبعد ما تعمل التشويس بتاعك A or B or C you need to press اوكي. خلاص معلش ناخد الكويستشن مره ثانيه.
انا كنت عارف ان الدكتور رياض هيلعب، كنت عارف ان الدكتور
يمكن تتغير النتيجه مش عارف.
اداك 20 جنيه، اداك 20 جنيه عشان
so yes for هتبقى A no B or no preference C and we press the green button okay على التشويس اللي هتختاره. مفيش بيج تشينج،
مفيش فايده.
دكتور محمود طيب. زادت اكتر في الفيمتو.
لا ده الموضوع عايز مجهود يعني. طيب الفورورد وباكورد من طيب thank you very much and I would like to thank the organizers for inviting me. الحقيقه this is me. انا very old school ودي عيادتي في حته شعبيه قديمه في واحد ميدان سيدنا الحسين في حته اثريه، وانا راجل كلاسيكي وبخاف اتغير. يعني خلينا نكون أمنا مع بعض. What is the real problem and challenge of keratoplasty؟ التشالنج الحقيقي مش إن أنت تعمل بالفيمتو أو تعمل بأي تكنيك، الفيمتو هيسهل لك وكل حاجة، بس التشالنج الحقيقي إن الخواجة يبعت لك قرنية تاني يوم تعمل العملية تلاقي العيان ده كده، اللي هي الأكيوت أو برايمري جرافت فيلير. لأن إحنا خلينا نكون أمنا مع بعض، وهم ما بيدوناش أحسن حاجة عندهم، هم بيدونا الثيرد كواليتي. إحنا كنا شغالين في المركز اللي إحنا بنشتغل فيه في امانه الله لغايه لما قعدوا يعارضوا فيا، لغايه لما جابوا لي الفيمتو ليزر، وانا زي ما انتم شايفين خايف ومرعوب منه، واضطريت ان انا واقف. Surgeons today they need something more. They need the word reproducibility to do the same technique, the same patient for every patient, and he gets the same result. This is what the surgeons need today, and that's why the femto is tackling this feeling of the doctors. And that's why the companies are doing this. But this is my disappointment, the major disappointment. It's very expensive, takes more time, definitely, and the expectation is high. انت كتبت عقد مع البيشنت ان انت هتديله femto laser result, and this is very dangerous. It doesn't solve the problem of suturing unless you find something else. And this is the point of view, eliminating the technical talent. You are losing your technical talent, your surgical skills are diminishing with the machines, and that's why I'm disappointed. Let me conclude with you the technique of DULC, that the way that we have learned long time ago, we inject air and we get big difference. When big difference in keratoplasty, and we all know that the major keratoplastic patients are keratoconus, because we are in Egypt and the Middle East is like this. So for 12 million of Egyptian pounds, you are paying for only 2 steps. The step, first one, which is the partial pterygination, and step 3 is the keratectomy or the anterior keratectomy of 80% of the corneal layers. Something that you can see and you can do it by yourself. And the rest of the steps, the separation of dual layer, the separation of dual layer and Dismas membrane from the donor and the sutures, with this is the major steps, and the injection of air to produce the big bubble technique, the injection of air, ya Dr. Riyad, to do the big bubble technique. And this, injection of the femto does not do the injection of air, which is the crucial step of surgery of DULC. It doesn't do it for you. You have to do it for yourself, even if you have the 12 million Egyptian pound machine. Instead, you have 3,500 Egyptian pounds, and you get this quality of patient, and this is the air bubble from inside. You get this quality of patient with any graft quality, والخواجة يبعت اللي يبعته، احنا مش هممنا، لأن الدلك you don't need the endothelium Desmet's complex. So, what is new? What did I do for DULC? Well, this is Anwar, the one who invented the DULC, the air injection or the big airway injection. I didn't change anything except injecting or making air visco replacement, and that makes the dissection easy. So what I learned from Anwar 1999 is the same thing that I am doing except this step. And this improves my surgical talent, and it improves my skills in doing the surgery. And you get this beautiful scene with the Desmet's beard, because you have injected the area, Dr. Riyad, by your hand, not by the femto. And Riyad Habibi, أخونا. If you fail the big bubble, the femto cannot save you. It doesn't save you when if the bubble fails. You have to find your way. And if you don't have skills for doing the surgery, the femto does not give you any more skills. It doesn't add anything. And you have to make manual dissection and go for it without needing the 12 million Egyptian pounds. Let me stress on this. And by the way, it's not only 12 million Egyptian pounds. You have to pay in maintenance. And for every case, الخواجة takes some money. الكون الخواجة أو الكارت، الخواجة بياخد فلوس وهو قاعد هناك. You have to make manual dissection. You have to find your way. Find a small bubble and enlarge it until you have dissecting the stroma. From this emphysema, that's nothing. You don't need this emphysema. It doesn't work for you. And you find your way until you really go for the Descemet's membrane or Descemet's dual layer complex, whatever you can. And the happy ending at the end, and you have this nice scenery. طيب, what is the problem when you find something like a double chamber and you have the hole like this here? You have the surgical talents and the surgical skills and the information that you can convert it to a survival case. It does look slightly ugly, but you can survive with the case. And you take the patient directly to the operation room and inject air فورا على طول, constrict the pupil, dehydrate the patient, and remove all the echoes from the anterior chamber, inject air the anterior chamber, اعمل شوية gapping عند الحتة اللي انت شاكك فيها, and wait for 15-13 minutes, remove some of the air, and you have a beautiful scenery like this at the end. صحيح, you can still see the hole, but the femto cannot save you from this complication. What saves you from this complication is your surgical skills, and you are practicing manual surgery. Well, this is another unusual complication. After 2-3 weeks of successful DULC, the patient gets very beautiful vision, and I am his hero. And he's very happy, he's a dentist, and suddenly he gets foggy vision. And you see that there is something here behind the cornea. معقولة, we have late onset, double chamber with stretch marks. نستعين بالأصدقاء OCT. They told me this is stretch marks and this is the Descemet's membrane. Here it's more clear, the report. Yes, this is a stretch mark, and the stretch mark does not give cloudy vision like this. And the cornea, the cloudy vision does not correspond to the cloudy cornea. The cornea is not cloudy. This is cloudy vision only. So I have to call for them, and I called my friends that helped me, and they told me, wait, this is not the Descemet's membrane. This is, for this furious patient, you have to take him to surgery. Once you take him to surgery, it is a retrocorneal membrane. The femtosecond laser does not help you in a case like this with such complication, and it does not remove for you this retrocorneal membrane. It does not help you in a complication. What really helps you in a complication like this is your surgical skills and talent and experience. If you have experience in manual surgery, definitely you will have good results. And this is dramatic improvement and really impressive when you see the patient later on happy, and now again, once again, I'm his hero. So this is the retroprothetic membrane that we usually see with the prosthesis, and it was very astonishing for me to see it with a case of DULC. To conclude, femtosecond or manual DULC, 12 million against 3,000 Egyptian pounds for each manual refine. 2 steps only that serves for this technology, but all inclusive for you when you do manual laser. You have to have 2 surgery rooms, and a delay, at least if you are very quick, of more than 15 minutes more for surgery, which is already long surgery. You have a high expectation patients. أنت كتبت عقد of excellence with the patient. You are doing him. You are a very elegant and the outdating technique of manual, you are not doing anymore. You are doing the cutting edge of technology. So the patient has a high expectation, while in manual surgery, العيانين الغلابة بتوعنا اللي انتوا شفتوا المكان اللي احنا بنشتغل فيه, more understanding. The femtolaser does not help in suturing, and so it does not help anything in post-operative astigmatism. But you need your surgical talent and you need your surgical skills in doing suturing of the keratoplasty to get better quality and better outcome of surgery. So it's all about surgical skills. If you stop using your surgical skills and depend on machines, definitely you might face such complications that the femtosecond laser, Dr. Riyad, does not solve it. So thank you very much, and I would like to remind you that this instrument is used 850 years later on in Cordoba Museum في Al-Andalus. The old one can still be used for long time of years. Thank you very much.
Thank you very much دكتور محمود. اعتقد ان دكتور محمود made it difficult for you شويه رياض. دلوقتي دكتور رياض شلش.
طيب الحقيقه دكتور محمود اختصر عليا الطريق جدا، وانا الحقيقه كنت عامل حسابي وانا مش هطول عليكم. هو دكتور محمود معترض على ال 12 مليون ماشين انها بتعمل 2 ستيبس. لا، هي 1 ستيب يا دكتور محمود اللي انا بعملها، لان انا بعمل بمشروم توب بس it deserves it. كلنا عملنا مانيوال دلك وعملنا كتير قوي، وعملنا الميلر انسيجن، وبعدين عملنا الاير بابل الجميله. يو نيد اول ذا سيرجيكال سكيلز لما تشتغل بالفيمتو. يو مايت ايفن نيد مور. بس التشالنج فين؟ التشالنج في البوست اوبراتيف ريهابيليتيشن بتاع العيان، بوست اوبراتيف استجماتيزم. دكتور محمود كان بيتكلم ان السوتشرز محتاجه سكيلز، والسوتشرز هتاثر على الاستجماتيزم. سوري، السوتشرز ما لهاش علاقه بالاستجماتيزم وات ايفر يو دو. The wound, astigmatism is wounded by dependent. انا هفرجك على الوند اللي كلنا عملناه. كواليتي فين يا ابني؟ لما بنيجي نعمل بالفيمتو احنا بنشتغل من الابيثيليال سايد، بنشتغل باوبتيكال بريسيجن. عندنا a regular wound all through size and quality. لما بنيجي نشتغل بالتريفاينيشن احنا بنشتغل من ناحيه من الابيثيليال سايد ومن ناحيه من الاندوثيليال سايد. مهما انا كنت جراح عبقري هيجي لي ده الوند جيبنج. مور اوفر انا عملت تيشو ديستراكشن. الصوره دي معموله ده الكترون مايكروسكوبيك بيكتشر اوف ا كورنيال تيشو. دي معموله بالسوبر بليد اللي هو الالترا شارب ستينلس ستيل بليد. احسن شويه معموله بدايموند نايف. دي معموله بالفيمتو سكند ليزر. احنا عملنا تيشو ديستراكشن. ات ذا اند اوف ذا داي هناخد ثيك ستريتشد ووند، هيبقى فيه ستريس لاينز، هيبقى فيه مارك. فاحنا بنشتغل احنا كلنا عملنا كده، كلنا عملنا دالك ومانيوال كراتوبلاستي كتير جدا. بس لما نيجي نبص من قريب شويه، لا، احنا عندنا فرق فظيع في الكواليتي، فرق فظيع في الايرلي ريهابيليتيشن وفي البوست اوبراتيف استجماتيزم. الحاجه الثانيه الديسيجن بتاع السايز. لما بتيجي بتشتغل بالمانيوال انت عندك في تلت ايذر وانت واخد من الاندوثيليال سايد او واخد من الاندوثيليال. ديفينتلي عندك تلت، مش ممكن ايدك مظبوطه 100%. انما الاوبتيكال بريسيجن موضوع تاني. فنو واي ان احنا هنكومبير المانيوال مهما كنا عملنا ومهما كنا عندنا اكسبيرينس. فالاستجماتيزم از ووند ديبندنت. احنا عندنا a very bad quality wound في تيشو ديستراكشن، باد سايزنج، وجيبنج كمان. فالفرق كبير جدا. في الاخر انا بشوف طول الوقت بشوف حالات كراتوبلاستي معموله والجرافت كلير والدنيا جميله، والعيان فرستريتد لان عنده فيجوال ديسابيلتي، عنده 9 و10 و15 استجماتيزم. احنا كنا عملنا بيبر اتنشرت في 2015 في الجورنال اوف كاتاراكت ريفراكتيف سيرجري على كومبايند استجماتيك كيراتوتومي مع ليسك في البوست اوبراتيف استجماتيزم. الكلام ده ما بيحصلش لما بنشتغل بالفيمتو سكند ليزر. بس في اند اوف ذا داي لا، في فرق. ده على فكره استاذ في كليه الهندسه كان عامل عين في امريكا. انا عملت له دالك في العين الثانيه وعملت له ري كراتوبلاستي في العين الاولانيه بعد 20 سنه. بصوا على السكار، اولموست مفيش سكار، مفيش ستريتش لان مفيش جيبنج في الوند. فالبوست اوبراتيف استجماتيزم بيبقى كنترول وقليل جدا. الحاجه الثانيه احنا عندنا 8 سوتشرز لو هنشتغل لاميلر و12 سوتشرز لو بنتريتنج. فمفيش برضو الستريس لاينز اللي موجوده مع ال 16 او ال 20 غرزه. فديفنتلي الفيمتو سكند ليزر اسيستد دالك using the big bubble technique and preserving all your surgical skills to control pre-operative, operative and post-operative complications محتاجينها يا دكتور محمود، هتوصلنا ل better results whatever you do بقى توب هات مشروم بات. انا بحب المشروم باترن بيجيب معايا نتائج كويسه قوي، بس طبعا ده مش ده. بس ثانك يو.
هنرجع بقى تاني لنفس السؤال لو تكرمتوا، نشوف حصل ايه في فكرنا بعد المحاضرات دي. ده اللي قبل كده 29. Don't forget the process A, B, C and OK. أنا شايف المانيوال خدت برضو percentage. Good work دكتور محمود، عشان you use the whole 12 minutes rather than 7 minutes. Thank you very much, and then we'll move to the next one.
Okay, the next debate is valves versus cyclodestructive procedures in refractory glaucoma. So the question is, do you prefer a valve implantation rather than cyclodestructive procedures in the refractory glaucoma? If yes, then you press A. If no, if you prefer cyclodestructive procedures, then you should press B. If you have no preference, you should press C. When a session نحن ندوس OK بعد الحرف. Okay, so Dr. Hazem Hilmi is going to speak for valves, and you already have a head start. حضرتك متفوق بنسبة 50% اهو، فنشوف بقى حضرتك هتقدر تحافظ على الصدارة دي ولا لا. اتفضل يا فندم.
ابدا، بس هو هنا. بسم الله الرحمن الرحيم. انا بشكر الدكتور سامح حبيب والدكتور احمد بيه على انهم ادوني الفرصه الجميله دي ان انا اتكلم. انا بعتبر معلش الجلوكوما كلام بايخ، واحنا مع الاسف مش محظوظين ان يبقى عندنا حاجات جميله نقدر نعرضها انها تو اتراكت يور انترست، لان احنا بنتكلم في ارقام. بس احنا هنحاول نبسط الموضوع. انا ما بعتبرش ان احنا في ديبيت قد ما بعتبر ان احنا شركاء في البحث عن حل لعيان ريفراكتري جلوكوما. احنا ما بنتكلمش في عيان جلوكوما، احنا بنتكلم في عيان ريفراكتري جلوكوما، لان الريفراكتري جلوكوما هي الجلوكوما البورلي ريسبونسيف للتراديشنال تريتمنت اللي احنا عارفين، يعني لا ميديكال ولا سيرجيكال، وعملت كل اللي تعرفه، والعيان ده عنده مشكله كبيره ما احناش عارفين نحلها وعايزين ننزل التنشن. والعيان نوعين، يا بيشوف يا ما بيشوفش. اللي ما بيشوفش مشكلته محلوله، بنتكلم في بين، لكن اللي بيشوف هو ده المشكله، وخصوصا لو مشتركين مع ناس تانية. والريفراكتوري جلوكوما اسم كبير تحته النوفاسكولار واليوفيتيك والبوست بي بي والبيدياتريك والانجل ريسيشن والريبيتد جلوكوما سيرجريز. كل واحده من دول لها خصائصها وتقدر تتعامل معاها ازاي، وعايز اوصل بيها لبر الامان. كل دول ما هماش عيان تنشن عالي وجلوكوما، ده تنشن عالي وجلوكوما لحاجات كتير ومر معانا بتجارب كتير. الجولد ستاندرد طبعا هو الاس اس تي سب سكير ترابيكلاكتومي اللي كلنا بنحبها وبنعملها، وبقى الميتومايسين والانتي ميتابولايتس فادتنا، لكن بتيجي تخذلنا في الحالات دي بعد ما بعمل مره واثنين وثلاثه واربعه واحط كل حاجه واجرب كل الكونسنتريشنز اللي كلنا سمعنا عنها وعارفينها وقريناها وجربناها، وبرضه مفيش. طب هنعمل ايه؟ ظهر الجلوكوما درينج ديفايس في الحته دي. الجلوكوما درينج ديفايسز دول نوعين، حاجات فالفيد وحاجات نون فالفيد. الفرق كان ما بينهم الكارثه الكبيره انك بعد ما بتحط الصمام بتوصل فلويد من الاكواس فلويد من جوه من الانتيريور تشامبر اللي بره، فبيحصل سيفير هايبوتوني. حصل الكلام ده مع النون فالفيت، فبدانا ندور على حاجات كتير، اللايجيشن وحاجات كتير مش هنخش فيها. فطلع النون فالفيت حللنا المشكله، والنون فالفيت ده بيشتغل على فينتوري، ان هو فينتوري سيستم، يعني الجهاز بليتس وممبرينز بتفتح بس لما الضغط بيعلى عن اللي انا عايزه، اللي هو 8 ل 12 ملم ميركوري. لكن حتى الحكايه دي اثرت شويه على الريزلت في ديكريز اوف انتر اوكا بريشر، فبداوا يحلوها بانهم نقلوا من البي ام ام اي بليت الى السيليكون بليت، فبقى الهيلينج حوالين البليت اقل، فبقى الفلتريشن احسن، فبقت النتائج افضل. انا هتكلم على احمد فالف كنموذج، مش علشان حاجه خاصه، علشان هو ده اكتر حد بنستعمله هنا في مصر وكلنا عارفينه ومتعودين عليه عن الحاجات التانية كمثال للنون فالفيد. فكره الجلوكوما دريج ديفايس يا جماعه ناحيتين الاكواس من الاي سي الى حته ورا خالص بعيد عن البيري ليمبال اريا، لان عشان كده في ناس تعتبر فاكره ان الاكسبريس شانت از فالف، الاكسبريس شانت از نوت فالف. احنا عايزين ننقل الاكواس من الاي سي الى حته فيرجن ما فيهاش كونجنكتيفال سكار وما فيهاش انفلاماتوري ممبرينز، لان العيان اللي عندنا ده ما هواش عيان فيرجن. طيب ايه الكومبليكيشنز اللي هتخوفني؟ هيخوفني الهايبوتوني، وقلنا دي هتتحل بحاجات، والاكسسيف فايبروس حوالين الكبسول، والايروجن اوف ذا تيوب، والبليت ايدج سندروم. وانا بحاول اقول احنا عملنا ايه والمشاكل ايه ونقدر نحلها ازاي. هقسم الريفراكتوري الى الريفراكتوري جلوكوما، الريفراكتوري بيدياتريك جلوكوما، ودول نوعين: الجلوكوما اللي مع البرايمري كونجينيتال جلوكوما، وبنعمل الجونيوتومي وبنعمل الترابيكولوتومي، ونتائجهم حلوه قوي من 80 ل 90%. بس بوصل ان انا بعمل الجونيوتومي والترابيكولوتومي 4 مرات كده و4 مرات كده وبرضه مفيش ريفراكتوري. ابتدي اعمل اس تي، بلجا بالاس اس تي للاطفال، فيلير ريت عالي، ابتدي احط الانتي ميتابولايت، يبتدي يحصل لي سين فاسكولار بليب ولايبيليتي الانفكشن ولايبيليتي الرابشر والريستريكشنز، فابتدي ادور على حاجه ثانيه. هل الصمام يبدا يحل لي المشكله دي؟ يبدا يحل المشكله دي. تجربتي معاها عملتها في خلال 4 سنين، عملت 33 حاله من الترابيكولوتومي ترابيكلاكتومي وزيهم من الاحمد فالف. النتائج في الاثنين متقاربه، بس الاحمد فالف اداني مور كنترول عن الترابيكولوتومي ترابيكلاكتومي، وحماني من ان انا احتاج الانتي ميتابولايت. والكلام ده في اكدته بيبر اتنشرت في سبتمبر 2018، عملت على البرايمري كونجينيتال جلوكوما وكمان على السكندري بيدياتريك جلوكوما، في نتائج وصلت ل 91% بعد 4 سنين. لكن في دروباكس مخوفه الناس. في ناس بتقول ان التيوب اروجن ده احتمال كبير والسكندري انفكشن. بنقول ان ده ممكن تعمله لو انت عملت حاجه ظريفه جدا، عملت الانسيرشن للتيوب بتاعتك خلال تانل، مش خلال فلاب ولا بتحط عليها باتش. انا بعمل تانل 6 مللي 3 واطلع التيوب وارجع اعمل 3 تانيين وادخل التيوب جوه، ما بحطش سوتشرز خالص. ده بيعمل لوكاليزيشن كويس ويخلي التيوب ستيبل، ومع الاستابيليتي دي تبقى انت ضامن ان مع اي فريكشن مع اي حركه ما حصلش حاجه وحماتك من اللايبيليتي الانفكشن. وكمان الحاجات دي غرزك تكون مظبوطه، ما تسيبش غرز بره، البيري ليمبال اريا تبقى سموث، ومع الانستراكشنز اللي هتديها للبيرنتس، والكلام ده اتفق عليه الناس من 2011. طيب الريفراكتوري فاسكولار جلوكوما الكابوس الاكبر، بيشكل 30% من الريفراكتوري جلوكوماز، ودي بروجريسيف ديزيز ريزيستنت تو التراديشنال تريتمنت، لان فيه اريس نوفاسكولايزيشن، ساينيكال انجل كلوجر، بروجريسيف انفلاميشن للانتيريور تشامبر، والباثوجينيسيس از مالتي فاكتوريال، داخل معانا فيها الدايابيتس والفاسكولار انسر. السكسيس اوف سيرجري واللونج تيرم نورماليزيشن اوف انتر اوكا بريشر بيعتمد على انك تصلح حاجات تانية جنب التنشن، ومن هنا ظهر الانتي فيجف. لقينا ان احنا لو حطينا الانتي فيجف قبل ما نعمل الاحمد فالف دي هتحسن النتائج، لانه هيقلل حدوث الهايفيما والكرويدال ديتاتشمنت والفلات اي سي والكورنيال ديكمبنسيشن، بالاضافه لانه هيحسن السكسيس ريت. والكلام ده اتفق عليه ناس كتير من 2015 و2016 و2017. ليا تجربه من 2012، سنتين كنا انا واحد الزملاء الدكتور محمود ليلى فيتريتنال سيرجن، كنا بنتعامل مع الناس دي بطريقه هايلي اجريسيف، ان احنا نعمل بي ار بي، هايلي اجريسيف بي ار بي، علشان نوكيل ذا ديزيز ونحقن انترافيتريال انتي فيجف وبعدين نحط الفالف. وقسمنا الناس ال 50 واحد ال 25 حطينا الفالف و25 حطينا الترابيكلاكتومي. لقينا حتى الترابيكلاكتومي بتنجح، ولقينا ان الترابيكلاكتومي بتقرب من الفالف طالما انا بتريت الكوز بتاع النيو فاسكولارايزيشن عن طريق ان احنا بنحقن الانتي فيجف. لقينا التنشن نزل من 46 ل 12 و7 والماسك بي ار بي في سنتين، ولقينا ان 82% من الناس حتى بقوا مش محتاجين تريتمنت خلال 24 شهر. طيب يبقى انا علشان النيوفاسكولار جلوكوما لازم تو بروبر مانج، لازم نماكسمايز الكنترول اوف نيوفاسكولارايزيشن وريديوس الفيجف علشان نمبروف السكسس ريت في مع الفالف ونكونزيرف اللونج تيرم كنترول في انتراوكا بريشر ونقلل السكارين كاسكيد ونقلل البوست اوبراتيف بليدنج وانفلاميشن والكورنيال ايديما والهايفيما والفيتراس هيموريدج اللي بيخوفونا كلنا، ونقلل النمبر اوف انتي جلوكوما تريتمنت كمان. الريفراكتوري بوست فيتراكتومي جلوكوما بعد ما الفيتراكتومي اصبح بيتعمل بكم كبير جدا الايام دي، بيجي لك البوست فيتراكتومي جلوكوما. الناس كلها ما سكتتش، جربت الفالف وثبت لحد 2008 ان في سكسس ريت بيصل الى 80% ل4 سنين. ده كمان قالوا ان احنا ممكن نحط في 2018 ممكن نحط الفالف مع الفيتريكتومي ان ذا سيم سيشن في عيان انت متوقع يا هو جلوكوما سوتنشن ان كنترولد او كنترولد بميديكال تريتمنت، يا متوقع انه هيبقى ان كنترولد بعد التريتمنت، فممكن تحطها في نفس السيشن. الكابوس الثاني هو البوست بيكي جلوكوما، والبوست بيكي جلوكوما عندي مشكلتين، مشكله ان انا كنترول التنشن ومشكله الجرافت سرفايفل اللي هي الراجل باعت لي العيان بتاعه بوست بيكي جلوكوما عايز نرجع له الجرافت بتاعته. الجلوكوما از سكند كوز للفيلير اوف جرافت بعد الريجكشن، فانا مش عايز، انا عايز اقلل ما ساعدش. جربنا لنا تجربه في الحكايه دي، حطينا الاحمد فالف في البوست بيكي جلوكوما وادتنا نتائج هايله زي ما انتم شايفين. خلصناها في 2016. الكلام ده البيبر بتاعتنا دي سايتد باحد الاساتذه قال ان الفيلير ان الجرافت سرفايفل او الجرافت فيلير 50% مع الاحمد فالف، لكن حالاته كلها كانت حالات كومبليكيتد بي كي في، فغالبا الريجكشن كان مشترك ما بيننا. الناس ما سكتتش، قالوا لا كل ما تدخل بدري كل ما النتائج تبقى احسن بالنسبه للجرافت سرفايفل. وفي ناس قالت ان انت لو حطيت الفالف بارس بلان احسن ما تحطه انتيريور، مش هيأثر على النتيجه بتاع الانترا اوكا بريشر كنترول، لكن هيحسن لك الجرافت سرفايفل. في حالاتنا لقينا ان انت لو عملت بروبر بوزيشننج للتيوب وحطيتها في البلين الصح زي ما هقول في خطوات بسيطه، وضمنت ان انت تقلل الاندوثيليال تاتش، انا اعتقد ان السرفايفل ريت هيبقى احسن، خصوصا لو الحاله ما فيهاش مش ماشيه تولز ريجكشن للديزيز الاصلي. في اليوفيتيك جلوكوما الناس بحثت الاحمد فالف ولقت ان نتائجه هايله، وصلت 98.5% في اول سنه وبتنزل ل 70%. بعد كده بعد 5 سنين، السلايد دي اهم سلايد طلعت بيها بعد هذه السنين في الاحمد فالف، ان انت في بعض خطوات تريكس يمكن تساعدك لو عايز تعمل الحكايه دي وانت بتبحث عن النتائج الكويسه. انا وانا خارج دايما بحط الاير ده بيقلل الهايبوتوني وما يدخلش بلاد جوه التيوب فيقلل الكواجولم اللي بيدخل ويقلل الفيلير، وفي نفس الوقت هيقلل الهايبوتوني. لما تيجي تلوكالايز التيوب بتاعتك املى الاي سي هيلون او املى الاي سي ميسايل، هيديك فرصه انك تشوف الاناتومي كويس ودايسكت كويس وتعرف تحط التيوب بتاعتك في البلين الصح. لما هتحط التيوب حطها عبر سكليرال تانل بعد عذاب كبير جربناه مع كل حاجه، سواء كان تحت فلاب او تحت او في جروف او بنغطي بسكير باتش. لقينا ان انت لما هتحط في سكليرال تانل دي احسن حاجه تفكسيت، زي اساتذتنا وزملائنا في الباكل دلوقتي بقوا يحطوا التاير والباند جوه سكليرال فلاب. لما تيجي تقفل كويس، اقفل التينول في 1 لاير وبعد كده اقفل الكونش في 1 لاير وانديفيدوالايز، يعني كل اعرف هتحط التيوب لمين في اي مكان وهتحطه ازاي. فورورد موف ما تدخلش اكتر من 1 ل 2 مللي بس، وتكون بيفلت وتتاكد ان ما حصلش اي ادفانسمنت عشان تقلل الاندوثيليال تاتش. لو انت عايز مور فلتريشن في بليتس ثانيه ممكن تركب جنب البليت الاولاني بكوندكتور. خليك دايما جاهز للخطوه الثانيه وانت بتحط الفالف. اعمل حسابك لو انا حصل عندي ريجكشن، لو انا هعمل انترنال ريفيجن، لو انا هعمل اكسترنال ريفيجن، هدخل منين؟ احط التيوب بتاعتي تبقى اكسسبل، ان انا لو هدخل اريفايز من جوه وهكذا. في الاخر مفيش ماجيك سيرجري للريفراكتوري جلوكوما، لكن امبروفنج سوري ممكن نرجع ثانيه، ولكن امبروفنج سكيلز والاكسبكتنج كومبليكيشنز والكوايت مانجمنت will improve your results. الريفراكتوري جلوكوما لها اكستنشن مع انذر بروبلمز that have to be strictly controlled زي الديابيتس والفاسكولار اوكلوزيف ديزيز، اوعى تنسى. وساعات حاجات بسيطه زي اليوفيتس وسيليكون ريمنانتس اكسترا ريسك تو بي كوركتد، يعني بعد ما تعمل كل حاجه تبقى في سيليكون بابل كانت مستنياك تروح داخله في التيوب تبوظ الدنيا. ثانك يو، شكرا جزيلا.
شكرا دكتور حازم. والآن مع العدو اللدود للأحمد فالف الدكتور أحمد مصطفى. سبحان الله،
ماله الفالف بتاعي يا هاني على رأيك، على رأي الناس. طبعا أنا مش عارف إيه اللي أنا حطيت نفسي فيه ده بداية يعني، ولكن خليني أقول لكم إن دكتور حازم قال في كلامه بعد ما حطيت الفالف بموديفيكيشنز بعذاب شديد، صح؟ كلمة قال بعذاب شديد بعد ما حطينا وشلنا اوكي. I will try just my best to explain the other point of view. Refractory glaucoma يعني إيه؟ يعني glaucoma we expect to be refractory to trabeculectomy, to the standard techniques. خلاص؟ وبتدخل فيها كل التايبس اللي my friend دكتور حازم قالها كلها. First of all, I am not against valves. Okay? I'm not against valves. بس عايز أقول لكم إن البروسيدور دي الفالف implantation it takes like 1 hour. I'm not against valves. Sacrodestructive procedures were introduced in the literature in 1933, so it dates back in the history. And then it passed through various stages of development from the transscleral diode that was established in 1992, so it's almost 26 years ago, so it should be withstood the test of time. And then it progressed to the endoscopic cyclophotocoagulation and to micropulse. And why that? Because it's a technique that's liable to refinements, which is something good. And because of the cycloablative procedure, and excuse me to use cycloablation instead of cyclodestruction because it gives you a bad impression, the cycloablative procedures include as well the introduction of ultrasound, high intensity focused ultrasound, which means that it is a procedure which is really needed. And then, why do I support the cycloablative procedures? The indications like that, they are indicated for refractory glaucomas, as we all know, but there are interesting reports about the use of the cycloablative procedures in primary glaucoma, a point that might reflect some safety of the procedure with results and follow-up up to 3 years. And then, what will you do when you implant a valve and the patient will have an elevated intraocular pressure? You know what's the conclusion in the literature? You will proceed to cycloablative procedures. And how often we face this procedure of scarring? I guess those who are working in the field of glaucoma, they know the figure, and sometimes they don't pronounce it, but you know. And this is the diode machine. It's a simple machine where you have to adjust the power and the duration, and you will see the number of the shots. Now, cycloablative procedures, we had the wrong concept that's applied on painful blind eyes. No, this is not true. And cycloablative procedures are applied on eyes with good vision. How good? Good seeing eyes. There were no serious complications such as hypotony, phthisis bulbi, or sympathetic ophthalmia in some of the studies. And the pressure, and they kept their vision, though there might be some decline, but they kept their vision. So that reflects the safety of the procedure. Do we meet serious complications? To be honest, in the literature, we can have hypotony from 0 to 17%. But this is mostly in neovascular glaucoma. And so what? We are dealing with the serious stages of the disease, and we expect some compromises. We will not be 100% in every case. But the good point with the diode, it is titratable, so that I know that with the treatment regimen, I will get hypotony. With the other one, I will not get. So you can't titrate. Now, this is a good example of cyclophotocoagulation to apply and also for the valve to apply. But you can think a patient with post-vitrectomy keratoplasty with staphylomas elsewhere, how are you going to put the valve? How on earth are you going to dissect enough conjunctiva to place the valve underneath? The valve is a body. Okay? So, and I guess in those types of cases, it's quite easy to proceed for cyclophotocoagulation, which I really admire and produced in this case. Quite easy, it took like a few minutes. Now another scenario, and that patient came with a pseudophakic, yes, on full antiglaucoma. I planned to put a valve. And then what happened? I wanted to have enough conjunctiva. The whole conjunctiva is totally plastered on the sclera because an aging, extensive antiglaucoma medications, there is no place for anything. I can't do even trabeculectomy. Think about the valve. So what to do? The only option I'm left with is to do diode cyclophotocoagulation, a one-eyed patient and a well-seeing eye. I have no other option. Now there was some improvement with the introduction of the micropulse. We want to have less thermal damage, yes, true. With the micropulse, you know, that's now becoming available in the market. It's a variation of the diode cyclophotocoagulation. Just the micropulse, we use 1/3 of the cycle. So that less heat, and the results are so promising so far. And then I will not go into the detailed procedure. Good results, 75% reduction. These are our results when we applied on adults. And we just published in the Journal of Glaucoma, Dr. Yasmin and myself, we published on the micropulse in the refractory pediatric glaucoma. You know what do we call the micropulse? I like that. It is the mix. It is the mix of the diode. If you have the continuous wave, then we have the micropulse, which is the minimally invasive glaucoma procedure. And then further progress, and this is also available in the market, which is the high intensity focused ultrasound. So that if you would like to get the best of the cyclodestructive procedures, you have milder approaches, you have machines available, and you have more or less controlled outcomes as reported in the literature. I know the people who invented the valves, okay? And then to the left is Molteno, and to the right is Ahmed Mateen. But this does not mean I support their products all the time. The valve could be good like that. You're having a valve in the anterior chamber, but don't forget that we can have some problems with the valves regarding the intraocular pressure control on the short and long term, and the grossly visible complications. Tube retraction, tube erosion, a lot of tube things. And then we have what's now alarming and what is attracting there is a worldwide attention to this, is the progressive loss of corneal endothelium with the presence of implants in the anterior chamber. And then I can ask those who are placing valves, how often did they meet this complication of having a retracted tube and the patient comes to you and you kept helpless? How can I manage this? A lot of things you need to think when you place a valve. Another situation, just with mild trauma, the tube was extruded outside the eye, especially in infants where the eye has to grow. And sometimes the tube is extruded and then you have to cut it. And then when the tube is touching the cornea, and you can see this in the pediatric group, and I'm quite sure some of the pediatric glaucoma surgeons stopped putting valves. I'm quite sure of that. You can ask the leaders. And then I need to shorten this tube with the problems associated with that. And then when CyPass story, it is one of the MIGs withdrawn from the market because there is loss of endothelium. You know what was the problem? They realized something very important. For the implants available, they did not follow the endothelium more than 2 to 3 years. But with the CyPass, they followed for 5 years and they concluded we will get it out of the market. So what's with the big implants in the anterior chamber? No one evaluated after 3 years, and the world will do that. So at the end of the day, I will end having a cornea that's decompensated and the pressure that is not controlled. I need to think of something else. So when the pressure is elevated after putting a valve, what shall I do? Needling another valve? You know that when I asked Ahmed Mateen, he told me, yes, go ahead and put another valve. That easy, go put another valve. And then I'll go for cyclodestructive procedures. The answer is that the American Society of Glaucoma, they have decided to think that those who are having elevated pressure after valves, they will schedule them for another valve versus cycloablative procedures. Look, it is a precious procedure that you need all the time. And these are some of the publications we worked, me and Dr. Hal El-Hilali, we published in 2000 in Ahmed valve in pediatric glaucoma. You know, we kept putting tables of complications in every page. That was too much. And then, remember, I am not against the valves. Let us try just to have a comparison for the valves and cycloablation. The indications, valves and refractory glaucoma. For cycloablations, refractory and primary glaucomas. The procedure for the valve is an OR procedure. I can't do it in the clinic, yes? I need to spare at least 1 hour for that. And then for the cycloablation, it's an outpatient procedure. We teach the residents to do in the outpatient clinic. Valve is an intraocular procedure. Diode is an extraocular procedure. It doesn't need so much skills. With the valve, the most talented surgeons will take 45 minutes. The most talented surgeon. And then think about the average surgeon might have like 2 hours in putting a valve. And then few minutes. And then if you think that putting the tube through a tunnel is easy, no. Yes, it's very appealing, but you will never be able to exert a control on the entry of the tube into the anterior chamber. And then think of the cost. How much is the Ahmed valve? Anybody knows nowadays? 10,000 جنيه. It's too much. And then for the cycloablation, that's nothing. You can use the valves for so many patients. What about the repeatability? Then if you tell the patient that the valve will cost you like 10,000 and I will take like 500 pounds, okay? And then he will come to you and then we need another valve. What's the response of the patient? Not easy. But for cycloablation, we can repeat, no problem. What about the refinement of the procedure? You know that the cycloablation under improvements, but for the valves, no. They are very stagnant. What's the recent valve that you have heard about? Ahmed valve was introduced in the, I don't remember, in the 90s, Molteno in the 60s. And then what about the vision-threatening complications? With the valves, we get vision-threatening complications. We get endophthalmitis, we get corneal loss, decompensation, we get everything we can get with the valve. And then with the vision, with the cyclodestructive, yes, we can have hypotony. So we are dealing with risky eyes. We need to understand there are some compromises we can go through. Is it possible to titrate the valve to work or not? Unfortunately, we can't. It can induce pressure elevation hypotony. But with the cycloablation, I can treat 1 quadrant, 2 quadrants, 3 quadrants. I can make a deal with the patient. I'll go slowly. And what about the applicability? Valve is not for all eyes. When the conjunctiva is scarred, post-vitrectomy, and there is a buckle, how are you going to place a valve? You can't. Yeah, theoretically you can, but on the ground you can't. But for cycloablation, it is always possible. No one is not a contraindication.
Dr. Ahmed, please wrap up. Dr. Ahmed.
Yes.
Please wrap up.
I exceeded the time?
I think so.
There is no alarm. Okay. And what about the corneal endothelium? It is progressive. And then there is no data about the valves and subsequent procedure with the valve multiple, but with the cycloablation, they are usually few. But remember, I am not against the valves. A very successful story, a patient was treated with multiple needling following deep sclerectomy, and then she's a young patient. I did bilateral diode. Look, the IOP is 9.9 on combination therapy, but I'm happy. Another patient, one-eyed patient, aphakic, she's 32 female, I did her valve. I decided to put a valve. And what happened, she kept with me for like a few weeks, and then she traveled home, and then she gave me a phone call, my pressure is 40. And then please come back. And then she came back. I needed the valve. The pressure is again 40. And then I did her diode, and the pressure is controlled, and she went home happily. But remember, I'm not against what the valve, and thank you very much.
Thank you, Dr. Ahmed. دلوقتي عاوزين نعيد الفوت بعد البرزنتيشنز. عاوزين نشوف الأول الريزلت قبل البرزنتيشنز. يبقى كان 53% in favor of valve, 33% in favor of cyclodestruction, و 13% undecided. هنعيد الفوت بعد إذنكم دلوقتي. يبقى لو cyclodestruction يبقى A، لو sorry valve يبقى A، cyclodestruction يبقى B، و C يبقى no preference. وما ننساش ندوس OK بعد ما نختار الحرف.